Acute coronary syndrome is an accelerating ischemic continuum driven by the sudden disruption of an unstable atherosclerotic plaque. When this plaque ruptures, a thrombotic cascade triggers immediately. The size and stability of the resulting clot dictate the clinical presentation, ranging from unstable angina to a full-thickness ST segment elevation myocardial infarction. For a standard STEMI presentation, primary percutaneous coronary intervention, PCI, is the undisputed default strategy. This protocol is governed by a strict metric, achieving a door-to-balloon time of under 90 minutes to restore arterial flow and halt myocardial necrosis. While stenting swiftly resolves focal acute obstructions, it is inadequate for addressing diffuse, highly calcified, or complex atherosclerotic burdens. PCI wins the race against the immediate ischemic clock, but complex anatomies often require a complete surgical rerouting to ensure long-term survival. Specific anatomical and clinical variables determine when coronary artery bypass grafting surpasses PCI in the current guidelines. This tree maps revascularization guidelines. The first criterion for CABG is left main coronary artery disease. Second is severe three-vessel disease, especially with diabetes. Third is an ejection fraction below 40%. Finally, a syntax score over 32 flags anatomy too diffuse for stenting. For non-ST segment elevation ACS patients who meet these specific criteria, CABG is typically performed semi-urgently, following initial medical stabilization and diagnostic angiography. Coronary artery bypass grafting represents the definitive, evidence-based strategy for phenotypes where diffuse disease outpaces the physical limits of focal stenting. The highest-stakes surgical emergencies in ACS do not present on day one. They emerge as acute mechanical complications 3 to 5 days post-infarction. Transmural myocardial necrosis weakens the cellular architecture. Under the constant mechanical strain of internal systolic pressure, this necrotic tissue is prone to sudden structural tearing. The first of these emergencies is papillary muscle rupture, a complication that classically follows an inferior myocardial infarction. This wireframe reveals the vulnerability of the posteromedial papillary muscle, which relies entirely on a single blood supply. When this supply is cut and the muscle detaches, the patient suffers severe mitral regurgitation and rapid flash pulmonary edema. The second major complication is ventricular septal rupture, which typically complicates anterior or inferior infarctions. A septal rupture creates a massive left-to-right shunt, forcing blood across the ventricular divide and rapidly driving the patient into biventricular failure. The third complication is ventricular free wall rupture. This specific mechanical failure carries the highest risk among older female patients suffering from large transmural infarctions. Structurally, a true aneurysm involves the bulging of all myocardial layers with a wide neck. A pseudoaneurysm is a contained free wall rupture with a narrow neck, temporarily held together only by the pericardium and thrombus. If a free wall rupture remains uncontained, blood immediately floods the pericardial space. This rapidly progresses to electromechanical dissociation, cardiac tamponade, and mortality. Within this narrow window, survival hinges entirely on the surgeon's ability to outpace mechanical collapse with immediate aggressive reconstruction. Mechanical repair requires physiological support. The medical team must manage intensive perioperative pharmacology to sustain the patient before and after surgical intervention.
Dual antiplatelet therapy, or DAPT, is the mandatory pharmacological baseline, required for at least 12 months following the ACS event. Current guidelines prefer ticagrelor and prasugrel over clopidogrel for their superior clinical efficacy in acute settings. However, due to severe bleeding risks, prasugrel must be avoided entirely in any patient with a prior history of stroke or transient ischemic attack. Beyond antiplatelet agents, the protocol mandates initiating ACE inhibitors or angiotensin receptor blockers within the first 24 hours of the infarct. These agents act directly to prevent adverse left ventricular remodeling, providing a long-term survival benefit for patients with anterior infarcts or an ejection fraction of 40% or less. This aggressive stance contrasts with modern data on beta blockers. If the patient maintains an ejection fraction of 50% or higher, beta blocker prescription should be individualized rather than routine. Even the most perfect structural surgical repair will fail if the perioperative pharmacological environment is left highly thrombotic and hemodynamically hostile. The outpatient reality for an ACS survivor is stark. Roughly 50% of all recurrent post-discharge myocardial infarctions strike within the first 90 days. Preventing these early recurrences requires a rigid secondary prevention protocol, specifically targeted at aggressive lipid management. The guidelines mandate the universal initiation of high-intensity statin therapy immediately following the ACS event, regardless of the patient's baseline lipid levels. This line graph tracks a patient's low-density lipoprotein cholesterol over time. The first aggressive target is forcing a 50% drop in LDL-C from baseline. The second requirement is an absolute concentration driven below 55 milligrams per deciliter. A clinical failure state occurs when lipid levels flatten out above that 55 milligram threshold, despite maximally tolerated statins. Here, guidelines recommend escalating therapy. Adding non-statin agents forces the stubborn LDL-C safely below the target line. Discharging a surgical patient without enforcing these lipid targets significantly increases the likelihood of a recurrent cardiovascular event. The final and most frequently underutilized pillar of ACS survival is structured multidisciplinary cardiac rehabilitation. This is a Class 1 recommendation with significant statistical weight. Full participation yields a 26% relative risk reduction in cardiovascular mortality. This timeline maps the recovery matrix. Phase 1 begins immediately with early mobilization in the ICU. Phase 2 transitions to an outpatient exercise program, 6 to 12 weeks post-discharge. Phases 3 and 4 represent lifelong maintenance and cardiovascular conditioning. The primary systemic threat to this entire recovery continuum is patient non-adherence to complex, daily, post-operative medication regimens. To counter this, modern protocols employ a polypill strategy, combining aspirin, an ACE inhibitor, and a statin into a single daily dose. By eliminating adherence barriers, this strategy reduces cardiovascular mortality by 33%. Surgical success is finalized over decades, sustained by the rigorous integration of procedural intervention, pharmacological optimization, and lifelong rehabilitation.